Hello, everyone, and welcome to another week of Got a Problem with Your Knee? Ask Dr. P. My name is Luci Vigilati, and I am a VFit specialist here at Victory in Motion, the home of knee repair, not knee replacement. We are so excited to welcome you to our weekly show. We have a ton of questions that were submitted to our Skool group, Got a Problem with Your Knee? Ask Dr. P, our Facebook group, Knee Repair, Not Knee Replacement, and our social media accounts at Victory in Motion 1. First thing is first, who is Dr. P? Dr. P is a board certified orthopedic physician, a sports medicine specialist, and a regenerative specialist. He is the founder and CEO of Victory in Motion and the creator of the trademarked knee repair, not knee replacement program. Victory in Motion's mission is to make the world knee replacement free by 2043. Yes, you heard that right. Knee replacement free by 2043. Dr. P has over 25 years in orthopedics and regenerative medicine, so he brings a wealth of knowledge every week to the show to be able to answer your burning questions. So without further ado, let's welcome Dr. P.
Hey, Luchi. Hey, everybody out there. Thanks for coming again.
Yeah, good to see you. Good to see you.
Good to see you.
We got a good lineup of questions today. A few from YouTube, a few from TikTok, and then also, of course, from the school games and Facebook group. So let's get right into it. The first one is, can taping your knee help a torn meniscus?
So taping me like an athletic trainer types a knee.
Right.
So the question is, can taping a knee help with a torn meniscus? And taping a knee like you see an athletic trainer do on the sidelines, like when they tape an ankle, there are innovative ways that athletic trainers tape knees and they tape other body parts to help take the pressure off of certain injured areas and give support to injured areas. In general, taping a knee for a torn meniscus, I have never seen work really, really well because the meniscus is deep down inside the knee. And if it's flipping around or flopping around or it's unstable, taping externally isn't going to necessarily really help that knee. I mean, if you avoid twisting and turning, tape it so it doesn't twist and turn as much, it might help a little bit. But in general, I've really only seen taping help a little bit more for if someone has like an MCL, a medial collateral ligament along the inner side of the knee sprain, or an LCL sprain, or definitely the most common reason I see taping around the knee is for kneecap problems to try to prevent that kneecap from sliding out to the side and either subluxating or dislocating. So in general, I would say taping a knee for a meniscus tear is largely ineffective, or it might be done just to get the person through that game, but to try to get someone through a season with a torn meniscus by quote unquote taping, I have never seen to be super successful, although everybody's different, and I'm sure there's been a few cases where it has been successful, but I'd say most of the time it's not successful.
Right. Yes. Yeah, we've done a lot of that taping of the patella to avoid that subluxation a lot here. That was actually one of the first taping mechanisms that I learned here. So, yeah, we've done that a lot for the patella. Um, the next one we have is, can a meniscus tear show up on an MRI?
Yeah, absolutely. Can a meniscus tear show up in an MRI? Definitely. That's probably the best way to diagnose a meniscus tear with a test, a diagnostic test. So an X-ray is not going to show it. An MRI is going to show it probably, 90+% of the time. And sometimes if we're not sure and we can't see it, we'll do an MRI arthrogram, which is where we inject some magnetic dye into the knee, have them ride a bike. And if there's a tear, the dye will leak into the tear and you will see that better on an MRI, but that will require putting a needle into the knee and injecting the magnetic dye. Ultrasound is not very good for looking for meniscus tears if they're deeper in the knee. If they're right along the edge, the periphery, we can sometimes see them with an ultrasound. The best way to know for sure is to go in there and look arthroscopically. That's a surgery. Now, there are things called needle arthroscopes. There's a thing called the nanoscope. It's made by Arthrex, but there's others. So needle arthroscopes are literally the size of a kind of a larger needle, and we can look inside with a fiber optic needle and see if there's a meniscus tear. So that is something we can do in the office, and we do that sometimes if we're not sure. So MRIs are very good for looking for meniscus tears, but there are other ways as well.
The next one we have is what is the meniscocapsular ligament?
So the question is, what is the meniscocapsular ligament? And so menisco is meniscus, that's the shock absorber cartilage in between the bones. The capsule is the casing around the joint. Like when you rip a drumstick off a turkey, that casing, all our joints have a capsule or a casing. And that casing provides support for the knee, but it also, or any joint, but it also encloses the ends of the bone in a casing, and there's fluid within that joint, and the fluid helps lubricate the joint. And the lining of the capsule on the inside of the joint has what we call synovium. The synovium is the inside lining of the joint, and that has the cells that produce the joint fluid. So the casing is very important for stability and for the overall health of the knee and to keep the fluid in the knee. The meniscus cartilage, particularly the medial meniscus especially, attaches to that casing along the inside of the knee. So there actually is where the meniscus attaches to the casing is called the meniscocapsular ligament. Now, ligaments in general connect bone to bone. So a ligament sprain is an injury where the ligament that connects a bone to another bone gets injured. So you might say, well, the meniscus isn't a bone, and the casing around the joint, is that really a ligament? Well, it technically is because it connects the bone to bone, but the meniscus isn't. So that's a rare exception where there's actually a ligament that's not connecting bone to bone, but there technically is a ligament. It's the tissue that connects the meniscus, the shock absorber cartilage, to the casing or the capsule around the joint. And that can get injured. That you can sprain it. It can injured. It can get torn completely.
Yeah, that was going to be my next question. Is that a common meniscus? Would that be considered a meniscus tear when you hear or would that be called a ligament sprain?
Okay, so it's probably more of a ligament sprain because if there's no tear in the actual substance of the meniscus, but there's a tear where it attaches to the casing, the capsule around the joint, that's technically a sprain. Or it's a perfect peripheral meniscus tear, technically not a tear, but my point is there's a good blood supply in that area. So if that's the area that tears and we sew that meniscus back to that casing, as long as the casing's not too damaged, that will almost always heal. So it's not good to have any injury, but it's a
If you're
good one
going to,
to,
that's the
yeah,
spot.
it's a good one to repair. It's more peripheral, more along the outer edge of the meniscus, which is where the best blood supply is. So those will sometimes even heal on their own if they're small enough or they're not a full tear. If it's a grade one, it's just a stretch, or a grade two, a partial tear, they may heal on their own, or we'll oftentimes put PRP, platelet-rich plasma, or bone marrow aspirate cells, which has stem cells and other cells that help the stem cells to help that heal, especially if someone wants to get back faster, like an athlete or someone like that.
Right. Right. And in previous, I think it was 2 weeks ago, we talked about the different healing potentials of meniscus depending on where the tear is. So if you have time, go look back at those for anybody watching. And also on our social media page, we talk about the healing potential of the meniscus as well. So that's good. All right, moving on from meniscus, we're going to knee replacements. And the question is, what are the differences between a partial knee replacement and a total knee replacement?
All right. So even though we are Victory in Motion, the home of knee repair, not knee replacement, and I don't do any knee replacements anymore, I did them for years and years and years. I'm an orthopedic surgeon, but my goal was always to end the need for knee replacement, and I still have that goal. Our goal is to end the need for knee replacement by the year 2043. So the difference between a total knee replacement and a partial knee replacement is pretty simple. A total knee replacement is replacing the entire inside of the knee, whereas a partial knee replacement is only replacing part. Okay, well, that's pretty obvious. What people don't understand is when we do a knee replacement, we're not chopping the entire knee out. We're not cutting the whole end of the thigh bone and the whole top of the shin bone out of the knee and putting one in there, unless there's a really bad cancer or something like that. There are replacements for that. But in general, for arthritis, what we do is we cut the surface of the bone off. Okay, and we resurface it with a metal cap on the end of the thigh bone, and then we take the surface off of the shin bone and put a metal plate that has a stem that goes into the shin bone, and a little piece of plastic clicks into that. So now you have metal on plastic. And then the kneecap, we cut the surface of that off and we either cement or we can press fit if it has a metal back on it to get the bone to grow in it. We can put a resurface that kneecap with plastic or metal and plastic. And so it's a resurfacing. It's not a really, it should say resurfacing, not replacement, just as an FYI. Now, there's three parts to the knee, or three compartments, like we like to say. There's the medial, which is on the inner side of the knee, and then there's the lateral, which is on the outer side of the knee, and then there's the patellofemoral, the area underneath the kneecap where the kneecap communicates with the thigh bone, the femur. So those are three compartments. All three of those can wear out, and when all three wear out, that's when you get a total knee replacement or resurfacing. If only one of those three parts is worn out, most commonly the medial, but it can be the lateral and or the patellofemoral, then a partial knee replacement is called a hemiarthroplasty, and there are partial knee replacements for only one compartment or sometimes even only two compartments are replaced. So that's the difference between a total knee arthroplasty, a complete total knee replacement, or complete knee resurfacing, as opposed to a partial knee replacement or a hemiarthroplasty, where one or two out of the three parts is replaced.
Now, knee replacements being a pretty gruesome surgery and a pretty tough recovery for a lot of people. The next question is, can both knees be replaced at the same time?
Okay, so the question is, can both knees be replaced at the same time? And the answer is yes. It is a very painful surgery. And so we try to avoid doing both at the same time because then you don't kind of have a quote good knee to stand on. Even if you have bad arthritis in both knees, when you have that knee replacement on one knee, that's going to be your bad knee for sure. It's going to be way worse. And so you're going to have to rely on that other knee. Even though it's bad, it'll be your good knee. If the knee arthritis is so bad and that person is almost like in a wheelchair and they just can't walk anyway, sometimes it's indicated to do both knees at the same time. Um, with modern kind of nerve blocks and anesthesia and things like that, it's a little easier than it used to be, but the recovery, as you know, as a VFit specialist, a physical therapy assistant, and a strength and conditioning specialist, as you know, the recovery is so difficult from one knee replacement, let alone two, and so it's a very difficult rehab. Some people still do it, but in general, it's not recommended. Another reason it's not recommended is number one, it increases the operating room time, and the longer you're in the operating room, the higher the risk of infection, the higher the risk of anesthetic complications from the anesthesia. Also, there's a higher risk of not only infection, but blood clots, bleeding problems, blood loss, medical problems like heart attack, stroke, death. So in general, the risk of complications, the risks go up if you do both at the same time as well. So in general, we don't do both at the same time because it's riskier and it's way harder to recover from. But they can be done, and sometimes they are in certain circumstances.
Right. Yes. I've never worked with somebody with two at the same time, but definitely one at just the one knee replacement. It's pretty tough to recover from. And I could only imagine what two of them at the same time would be having to offload the weight on both sides and yeah, getting around the house. Definitely a challenge. The next one is, what are the risks and potential complications with a knee replacement?
So, what are the risks and potential complications with knee replacement? Um, any surgery has risks. So, one risk when we cut into somebody is always infection. So, there's always a risk of infection. The risk of infection, if you give someone antibiotics right before the surgery through an IV, is pretty low. That's the most important dose. we don't give it to them days before, and we don't even give it to them days after. It's that one dose you want to give within that hour of before you're making that incision. You want the antibiotics to be in the system at that point. And so that cuts the risk to 1%, which is pretty low. But since a million knee replacements or more are being done in the United States each year, 1% is still 10,000. And 10,000 infections in a knee replacement, each one of those is a disaster. And a lot of times the whole knee replacement, the metal, plastic, and cement needs to be removed. That person will need to be on IV antibiotics for 6 weeks. And then you might, if it goes away, you might be able to put a new knee replacement in. Unfortunately, my dad had an infection in his hip replacement 9 years after the hip replacement. So even after you heal and you recover, you're always at a higher risk of infection because you have artificial metal, plastic, and cement into you. Blood clots, very, 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 very high risk of blood clot if you don't go on a blood thinner. So if you get a knee replacement and you don't go on a blood thinner, you got at least an 80% chance of getting a blood clot in your leg and your calf. And other than that swelling and hurting and being painful, if that blood clot breaks off and goes to your lungs, that's called a pulmonary embolism, a PE, and that can kill you. 1/3 of pulmonary emboli present as death. You don't even know it hit you, you're dead. So we obviously want to lessen that risk of blood clot. And so people almost always are put on a blood thinner unless there's some major contraindication to doing it if they get a knee replacement. So blood thinners such as aspirin or Coumadin, warfarin, or Lovenox or other forms of injectable blood thinners are used nowadays. But the interesting thing is no one has found that one is necessarily that much better than the other. So it's kind of come full circle. It was always aspirin, and aspirin actually still is as effective as some of these more advanced, more expensive ones. But really, the most important thing, Lucci, and you know this, is that moving, getting moving right away, that circulates the blood and that helps prevent blood clots. So moving the ankles up and down, flexing the muscles in the calves, tightening up the quad muscles, squeezing your butt cheeks, that the muscles pump the blood and get it moving. Moving your ankles up and down 10 times every hour at least is huge. That's just as important in my mind as taking a blood thinner. Getting up and walking right away. We've always known that people who get up and start moving right away, you're like, oh my God, I can't believe I'm going to get up after a knee replacement. Yeah, we get you moving right away. That lessens the risk of blood clot. Now, another risk of anesthesia, general anesthesia, or lying down in bed and not getting up and moving is pneumonia or getting problems with your lungs. So that's always a risk. Stiffness, scar tissue, wound healing problems are a risk. It's a big, long incision. It's a thin area of skin right above your kneecap there. So having a wound breakdown, especially if someone's a diabetic, that can be a disaster. Like I said, stiffness, you get a lot of scar tissue, pain, chronic pain, numbness. When we make an incision in the front of the knee, straight down the front of the knee, there's a skin nerve that comes across the front of the knee. It's called the infrapatellar branch of the saphenous nerve. And when we make an incision in the front of the knee, that almost always gets cut. So people almost always have numbness or some decreased sensation along the lateral or the outer side of their knee. There's other big nerves and blood vessels and ligaments around the knee that we're using power saws and tools that could get injured. It's rare, but they can get injured. The peroneal nerve, which is along the outer side of the knee, if you put too much stretch on that and that gets stretched, you can get a foot drop. That's a big problem, as you know, trying to walk around with your foot flopping around. That's not going to work too good. So those are just some of the complications. I mean, heart attack, stroke, all those things from any surgery, they're always a risk. That's why we always have people get cleared by their medical physician if they're over the age of 40 or 50 or they have a lot of pre-existing medical problems or on a lot of medications. We'll have them get preoperative medical clearance and be optimized ahead of time. But a great diet, great exercise, good hydration, all those things are important. So those are just a small list of all the potential complications from a big surgery like that. The good news is, luckily they're low, but still, successful knee replacement is considered 85%. 15% of people are not successful. They have a complication or it doesn't work or whatever. So 85% is still good, but there's a lot of risk there. And the problem is with those risks, there can be some significant complications like, death. And so that's something that we do worry about.
For sure. 100%. Definitely scary. Scary risks. But you did say something that was probably the most scary out of all there, which was the blood clot in the lower extremity. So I got a question, and that is, what are the signs of a blood clot in the lower extremity?
Sure. So a blood clot, what are the signs of a blood clot in the lower extremity? A blood clot in the lower extremity, usually in the calf, it's usually going to be in the calf, um, uh, is called a DVT, deep venous thrombosis. So deep, the veins that are deep are the bigger veins, and venous are your veins. The veins are the blood vessels that bring the blood back to your heart. And then thrombosis just is a fancy word for clot. So a deep vein clot. And the signs are swelling in the calf, pain in the calf. You might have some redness in the calf, um, stiffness in the ankle, moving the ankle up and down, pain moving the ankle up and down. But it's usually mostly pain, tenderness, swelling. And now, if the symptoms switch over to shortness of breath or chest pain, that's a whole different ballgame. That means that clot probably broke off, went to the lungs, and that can absolutely kill you. So if someone has had a knee replacement and they have swelling in their calf or pain in their calf, absolutely 100% call your doctor or your surgeon immediately. If you have shortness of breath or chest pain, call 911 immediately, and go to the emergency room. It could be a blood clot, it can be a heart attack, it can be lots of different things. So those are basically what the signs of a blood clot in the calf are.
Nice. And I'm assuming that the symptoms are the same, but where would you expect these symptoms for signs of a blood clot in the upper extremity?
It's a lot less common to get a blood clot in the upper extremity, but it can happen. We've seen it in baseball pitchers, people who throw a lot and they're irritating or stretching the blood vessels, or people who have a clotting disorder, a genetic clotting disorder. It's the same thing, like you said, swelling, pain, maybe some redness, some tenderness. It can break off and go to the lungs as well. You don't see that as commonly, but it can. It can. And so chest pain, shortness of breath, same thing. If you get that, immediately call 911. If you're having swelling in your arm, immediately call your doctor, your surgeon, your physician, and get checked out.
And that would be in the armpit.
Well, in the armpit, it can be in the upper arm. I mean, if you have a blood clot in your upper arm, your whole arm is going to get swollen because the blood's not getting back to your heart. So the whole arm and the hand, everything can be swollen. Another thing is this. This is important both for lower and upper extremity. Oh, they still have a pulse. They're fine. I can still feel my pulse. Your pulse is one of the last things to go if you have a blood clot. So, I mean, the blood's getting in, so you're going to still have a pulse. It's just not going out because you have a clot. So just because you have a pulse does not mean you should ignore it. That's important.
That is important. And something people probably don't know. Um, Next one we have is, what are the risks and potential complications with PRP and BMAC injections?
Okay, so what are the risks and potential complications with PRP and BMAC injections? PRP, as you know, is platelet-rich plasma, and that is where we take blood, usually from the arm, if we're going to do only PRP. If we're doing bone marrow at the same time, we'll take the blood from the bone marrow. That's what we do. But either way, it's taking blood, spinning it down in a centrifuge, which is kind of like a washing machine. It spins it down really fast, and then the red blood cells, the white blood cells, the platelets, the plasma, the proteins, the fluid all separate out because they all have different weights. And the platelets are those things that when you cut yourself, you form a scab and they stop the bleeding and they prevent you from bleeding to death. But they have growth factors and they release those growth factors, and those growth factors stimulate new blood vessels and cells to come in the area, which helps it heal. So that's what PRP is. And we use it all the time to help areas heal, and restart the healing process and help people get better faster. BMAC, bone marrow aspirate cells or bone marrow aspirate concentrate, is taking bone marrow usually from the pelvis. It's not the hip, not the ball and socket joint. It's not the back, the spine, the pelvis. We have an area called the PSIS, posterior superior iliac spine, right underneath the skin, just above our butt, cheeks, on either side, and we can numb that up and we can draw and concentrate out the bone marrow, which has stem cells and it has other cells that help the stem cells. The cool thing about bone marrow and PRP is that we talked about with surgery, there's a risk of infection. Now, yes, putting a needle in somebody, whether it's an immunization, a shot, anything, there's always a slight risk of infection, but it's very, 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 very low, way less than 1%. And so the risk of infection with a surgery, if you get antibiotics, is about 1%. But it's way less than that with BMAC and PRP because we're just using needles. The other cool thing is that bone marrow and PRP both have antibacterial and antimicrobial properties, so they even lessen the risk of infection by themselves, just in and of themselves. But there is always still a very, very, very slight chance of getting an infection anytime you stick a needle in anybody. There's some bruising and maybe a little bit of bleeding, very low risk. Now, wherever we're sticking a needle into a vein or into a bone, I mean, if you put it in the wrong spot, you can damage a nerve or a blood vessel or things like that. But that's very, very rare as opposed to a surgery, which is a lot bigger area for potential for injury. And even that's pretty low. So it's much, much lower than surgery. There's been some studies done where, it compares I don't remember the exact study, so I'd have to look this up, but like, let's just say 1,000 surgeries to 1,000 bone marrow PRP injections. And the surgeries maybe have, 10 infections and 10 blood clots, whereas the bone marrow PRP literally had none. Not to say there's not a risk, but it's extremely low that there's going to be a complication. Now, anytime you stick a needle in someone, could the needle break or break off? Or, I mean, I've never seen that happen, but things like that can happen. So there are some risks. I think the most common risks are really just some pain from getting a needle stuck in you, but it's not even close to as painful as a surgery. And we numb the area up, but you still have to get a needle to numb it up, a very small needle. And then maybe bruising, a little bruising or bleeding. But even that is very rare. I mean, those are kind of the two main risks. Not that there's not some other very, very less common risks.
Right. And I think the differences in the risks and potential complications is pretty apparent. And like you were saying with the knee replacement, 85% of the time that usually you get good results with it, good results. Um, but those 15% you're stuck with metal and plastic that's not even working 100% correctly, and there's no going back from that. So that's scary.
That's true.
And that's what that leads into the next question. And so somebody got a knee replacement and they don't feel like they're doing well. Um, what are signs of a failed knee replacement?
Okay, so what are signs of a failed knee replacement? Is the question. And I think number one is pain. Not always, but number one would be pain. Number two might be swelling. Number three, stiffness. Number four, um, warmth or redness or signs of infection. Now, it depends on when we're talking. If it's before the incision is healed and you see drainage like pus or something like that, then yeah, you can really, infection's a lot easier to see. If it's years down the road, like unfortunately my dad had a hip replacement that got infected, pain, redness, swelling, even in the hip, though hip's pretty deep and knee's a little easier to kind of tell. But usually it's pain and if it's from loosening. So there's a lot of different reasons knee replacements can fail. It can be just wear and tear over the years, and metal, plastic, and cement is going to wear out. And after 15, 10, 15, 20, 25, maybe even 30 years if you're lucky, but on average, probably, 10 to 20 years, that knee's going to wear out. That metal, plastic, and cement is man-made, it's going to wear out. So what happens is those little metal particles get into your body too, by the way, but the plastic, when it wears down, that's what your body tries to absorb, but your body can't dissolve plastic, so it keeps secreting all these enzymes to dissolve the plastic because it's a foreign body, and our body's not used to plastic. So those enzymes eventually cause the bone to get soft between where the metal and the bone is attached, and you get a loosening there. You get a reaction where the bone gets softer and the metal gets loose from the bone, and that can give pain, and it can be kind of a subtle pain. If it gets really, really bad, you might hear if the plastic completely wears out and you hear metal on metal, you might hear grinding and all kinds of crazy noises. So sometimes noise, or what we call crepitus or clunking or clicking or whatever, that's a sign of a failure. Giving out, instability. There's a lot of different signs. But number one, if that knee is all of a sudden getting painful, if it's getting red or warm or you're getting fevers, I mean, that's like immediately go be worried about infection. If it's painful and swollen, but no signs of any infection, and it's kind of low grade, it could still be an infection. Definitely want to know. But if it's 15, 20 years since you've had your last knee replacement, maybe it is starting to wear out. Also, you might notice tenderness on the bone where the metal is attached to the bone. A lot of patients say it's tender to touch. And then mechanical symptoms like clunking or clicking or grinding or popping that weren't there before, that might be a sign of failure. So there's a lot of things that can happen. Bottom line, if you notice any of those things, talk to your surgeon immediately about it.
Yeah. And, you know, a lot of times with the bone, we treat the bone a lot to help the bone heal. And I was wondering, our mission is to be knee replacement free by 2043. And as of not right now, there is still need for knee replacements, not as much that are done, but in certain circumstances, is a need for a knee replacement at this point. Uh, do our programs help improve the success rate of a knee replacement? So like strengthening up that bone to have that implant be able to hold stronger, and things like that.
Yeah, great question. So, do regenerative programs or knee repair programs, almost prehab programs, help someone if they have to undergo a knee replacement? So, obviously, the goal would be to, if we're going to do a regenerative medicine program on somebody, we're going to strengthen their whole body. We might use laser on them, PRP, platelet-rich plasma, bone marrow aspirate cells, weight loss, anti-inflammatory diet, all those things. If they fail that and they still have pain, uh, they haven't wasted their time because if they have improved their range of motion, if they have gotten stronger, if they have lost weight, if they're on a better diet, they're going to heal better. They're going to heal faster. These people are going to do better than if they didn't prep ahead of time. Now, the goal is to not have to have them go through with a knee replacement or a joint replacement if they go through one of these programs. But in general, even before we had these programs, we knew that if someone needed a knee replacement, getting them into physical therapy ahead of time and getting their range of motion back, getting their strength, getting the swelling down, getting their joint mobilized, they were going to do much better after surgery. The biggest correlation with post-op range of motion is pre-op range of motion. So a knee replacement is not going to get you better range of motion on its own. You got to do that in therapy. So getting as much motion you can beforehand is going to help you afterwards. So the point is, your point is absolutely any of these programs that we do absolutely will help somebody if they need a knee replacement down the road. And the question about strengthening the bone beforehand and will that help a knee replacement? It's a great question. And what we have found is that with a total knee replacement, when you're resurfacing everything and maybe you're cementing it, it's not maybe quite as important to have good quality bone underneath. It's still important, but it's maybe not as important. But if you're only doing a partial joint replacement, a hemiarthroplasty, and you're only replacing, let's say, the medial side of the joint, and somebody has a lot of that stress or microfracturing, those bone marrow lesions, those soft spots, there have been studies that have shown that it's much more likely to fail because the bone is softer, and you don't have the other side of the joint, metal and plastic, to kind of balance it out. So for a partial knee replacement, hugely important to have strong bone underneath. And if you put a partial joint replacement on someone who has a huge amount of bone marrow lesion or soft spot or stress microfracturing, all the same thing, they have a higher rate of failure. And so reinforcing that bone ahead of time or just doing a total joint replacement is something that should be considered. So that is something that's very important, quality of the bone for a partial.
Definitely, and that kind of goes into the next question. Um, do our regenerative programs help improve osteoporosis?
So just in general, do regenerative medicine programs help osteoporosis? Uh, Yes and no, I would say. Directly, injecting bone marrow or PRP is not going to make someone's osteoporosis in their whole body or their hips, their spine, wherever their osteoporosis is. It's not going to necessarily make that better. But the total body fitness, where you're strengthening the entire body, because we know if you make your muscles stronger, that's going to make your bones stronger. And if you do weight bearing or impact loading exercise, initially start with weight bearing, but then if you can build it up to even maybe some impact loading a little bit higher, more impact, we know that impact loading exercise, weight bearing exercise builds strength in the bone. So absolutely, and by the way, losing weight taking some of the pressure. Now, not losing muscle, because if you lose muscle and you lose weight, that's not good. That's not going to be good for your bones. So having the right diet, so having the right genetic diet for you, some people don't eat enough protein and they need more protein. And you need protein to build bone and you need calcium, you need the right vitamins. And so getting on the right diet, losing weight or losing fat, I should say, which decreases inflammation, strengthening muscle mass, and weight bearing exercise is all absolutely going to help with osteoporosis. So, yes and no, but in general, yes, because we don't just do a shot and say, see you later. We do an entire program. And so, in general, regenerative medicine, if it's just a clinic that's only doing shots, that's not going to necessarily make osteoporosis better. But if they're doing a total body holistic approach, because some doctors also, we don't do hormones, but there is bioidentical hormone replacement therapy that will help with osteoporosis as well. At some point, maybe we'll get into that, but there's definitely functional medicine doctors out there who those type of things can help the bone as well.
Right. Yeah. Like you said, it might not be directly helping it, but if you're not able to weight bear on your knee, then you're not going to be able to do the exercises to do the weight bearing to continue building up that bone. So, you know, taking care of the root cause of their problem to be able to do things and do your full body fitness and things like that. So indirectly and directly with our VFit program definitely helps with that.
Well, that's true. So, right, if someone has really bad knee pain and they can't do the weight bearing or the impact loading exercise, and they're just a couch potato, inactivity leads to osteoporosis. And so, absolutely, I totally agree with you. You got to take care of that root cause, get rid of the pain, which is what the regenerative medicine part of things and all the other things, laser, everything else we do. Yes, getting rid of that pain. Now they're able to do a walk again. They're able to do weight bearing exercise, which will help their osteoporosis. So totally agree. Also, if your knee hurts and you gain weight and you lose muscle, right, your osteoporosis is probably gonna get worse. So totally agree with you.
Yeah. All right. Next we got, how does MLS laser facilitate healing?
Okay, so how does MLS laser facilitate healing? MLS stands for multi-wave locked system, and then laser is self-explanatory. That is a concentrated light that has many different effects depending on the wavelength of the laser and the strength of the laser. But MLS laser is multi-wave, meaning it actually has two wavelengths in the laser that are built together. They're locked together in a proprietary way, patented way. This laser is made in Italy by Asa Laser, and then Cutting Edge Lasers in Rochester, New York, is the North American distributor. So it's made in Italy, and it has a proprietary way where they lock the 808 nanometer and the 905 nanometer together so that they work synergistically. Both work, but if you lock them together, they work even better. They work synergistically, and they do it in a way where it can be a class 4 laser, which is the highest power laser, but it's the safest laser because class 4 lasers in general can burn people if you're not careful. But the way they patented lock this laser beam the two wavelengths, the MLS laser, it will not burn somebody. So it's the safest laser I know of. So very powerful and very safe. So that's what an MLS laser is. Now, what does laser in general do? Well, there's certain wavelengths of light between, let's say, 600 nanometers and 1200 nanometers, and so there's certain wavelengths of light which can stimulate your mitochondria. So just like light can stimulate plants to grow, photosynthesis, believe it or not, light can stimulate humans. That's called photobiomodulation. So let's say you have an 808 nanometer light wave, and it will go to the mitochondria, which is the little powerhouse of the cell, if you remember from high school biology. Hopefully, you all remember that. But your mitochondria provides energy to your body, ATP. And so the laser will make that mitochondria produce more energy. So that's one way it helps with healing, makes your cells work better, produces more energy. You need energy to heal. Number two, it decreases swelling and inflammation. We know that when someone has an injury, it swells up, inflammation causes stiffness, causes pain, and getting the inflammation, all the bad stuff out of there allows the good stuff to come in. So the laser also increases blood flow. So bad stuff out, good stuff in, that helps with healing. And then there's also a direct pain relieving effect. The laser beams inhibit the painful nerve fibers, the nociceptors that cause pain. So if you're in pain, you're not going to want to do the exercises and you won't heal as fast. Whereas if we can get rid of the pain and we can increase the blood flow and decrease the swelling and inflammation and stimulate your mitochondria, it's going to make you heal better and faster. Absolutely works. Tons of evidence. We've seen it, ourselves clinically, but there's lots of studies that show that photobiomodulation helps people heal and helps humans heal.
Yeah, definitely. Yep, we see it every day. I've seen it for myself on my thumb. It definitely, especially with the thumb, smaller joints, able to absorb the laser a little better. So it happened pretty quick for me, which actually prevented me from having to get surgery. So it definitely does work. The next one we have is what criteria makes someone a candidate for our regen programs?
What criteria makes someone a candidate
Or maybe
for
it might be easier to say what would disqualify somebody from being eligible for our programs, or whichever way you think is easiest to answer that question.
Okay, so just in general, what qualifies someone for a regenerative medicine program or what disqualifies them from a regenerative medicine program? And regenerative medicine is using the body's own ability to heal itself. And so um, every day, just simplifying things, but every day we walk around, we do exercises, whatever we do, we break our bodies down, cause little microscopic cracks in our bones, in our muscles, in our tendons, in our ligaments, and then we go to bed at night. And again, I'm simplifying things, but our body repairs itself, and then we don't fall apart, right? And so as we get older, that ability to repair ourselves, it's still there, it's just not quite as good. So regenerative medicine harnesses the power of our body's own ability to heal itself, most commonly using platelets, which are those things that, like I said earlier, when you cut yourself, you form a scab, they stop the bleeding, but they also have growth factors, so they stimulate healing. And those growth factors are kind of like fertilizer. So if we can take those platelets and concentrate them, it's like a concentrated miracle grow to the area that we want to try to either restart the healing or get to heal. And so that's kind of one regenerative medicine technique. Another is the cells are what actually do the work. So if we can take somebody's stem cells and other cells that help the stem cells, which stem cells are present in the bone marrow, they're present in fat, they're present in all our capillaries, our little tiny blood vessels, and stem cells turn into other cells, but they also direct other cells on how to repair areas of the body. So they're kind of like boss cells. And in the bone marrow, I like it because there's stem cells, but there's other cells that help the stem cells, such as macrophages. There's also other white blood cells that help fight infection and things like that. So using cells, our own cells, to help our bodies heal ourselves and remodel ourselves and repair ourselves is also a part of regenerative medicine. We talked about laser, that's also using light energy to help our bodies heal ourselves. So frankly, almost everybody is a candidate for regenerative medicine unless you're dead. I mean, even the sickest people still have some ability to repair and heal themselves. And our job as regenerative medicine specialists is to harness that ability and help that person heal themselves. Now, yes, you can take cells from other people, donated cells and donated growth factors and things like that, and inject them into people and help them, but that's not allowed in the United States right now. We are affiliated with a clinic in the Caribbean, the Garm Clinic, where that can be done. But right now, that's not available in the United States. And frankly, I like the idea of using somebody's own. I mean, I had it done on myself, so I used my own cells to help fix my elbow tear. And so that's regenerative medicine. So who qualifies? I mean, pretty much everybody. Now, who disqualifies? People who have a blood disorder because we're taking blood or bone marrow. So if you have a blood cancer or you have a bone marrow cancer, or any cancer for that matter, we're going to have your oncologist decide whether or not it's okay to do the procedure. Because last thing we want to do is take cancer cells. If you have cancer cells in your blood or you have cancer cells in your bone marrow, take them from one area and put them into another area. Now, having said that, I don't know as though there's any definitive study or evidence that shows that even someone who has like a leukemia or a lymphoma, a blood cancer, is going to spread it somewhere else if we do one of these procedures on them. But we absolutely will always ask the oncologist, and sometimes they'll say, "Nope, can't do it at all," so that'll disqualify them. Or they have active cancer right now. Let's wait till it goes into remission. So we can't do it. No. Or they might say, "Hey, yes, they have a blood cancer. It's in remission, and we've done studies, and it does not show it's anywhere in their bone marrow. It hasn't metastasized or spread to the bone marrow. And yes, go ahead and take blood or bone marrow." We've had that instance. We've also had instances where, interestingly, it's in the bone marrow, it's spread. So we had a lady who had breast cancer, and it spread to her bone marrow. But then they treated her, and it went away, and she was in remission and there was no active cancer known. And they said, well, don't take it from the bone marrow, but you can take her blood and do PRP. And same thing with laser. Technically, laser's not supposed to be done over an area of active cancer. And if someone has a blood cancer, again, theoretically, there's, it could be throughout their whole body. And so anywhere you laser, theoretically, could it make the cancer cells grow faster? No definitive evidence in humans that shows that, but technically, a contraindication of laser is using over an area of direct cancer. Again, with no 100% definitive study that shows that's bad to do. But what we'll do there as well is if you have an oncologist and you unfortunately have cancer, we will ask that oncologist, your cancer doctor, is it okay to do? And frankly, we've had some oncologists say, hey, nothing else has helped this person's pain. I remember this one woman, she had it bad in her hip, and they're like, go ahead and use the laser. There's nothing, we've tried all these other things, nothing else has worked. It can't, hurt to try. And actually, it helped her pain a lot and didn't necessarily spread the cancer, which was already spread anyway. So those are kind of the contraindications. There's others. If someone has like an active infection going on, if somebody has low platelets, if somebody has low, their bone marrow has an abnormality to it. So there's certain things that disqualify people. But in general, if you're a human and you're alive, and you don't have one of those rare contraindications, you're a candidate for regenerative medicine.
Yeah. And we're the home of knee repair, not knee replacement. You were saying you did the program for your elbow, and I've done a lot for people's shoulders. Are the injections for every body part as well?
Right. So we are Victory in Motion, the home of knee repair, not knee replacement. And yes, that is what that process has been a long process. And it's too long to get into, but when I first saw a knee replacement surgery 33 years ago, I was a third year medical student, and I asked the surgeon if there was any way to repair a knee or grow back new cartilage or cure arthritis. And I said, is there any way to repair a knee and not replace it? And the surgeon didn't even get a chance to answer. The chief resident said, no, there's no way to repair a knee. There's no way to grow back new cartilage. There's no way, to cure arthritis. There's no way to repair a knee and not replace it. We have to do a replacement. And so I just thought that was kind of crazy. I was always a Star Trek fan, and I liked Dr. Bones McCoy, where he had a tricorder and he could diagnose things without having to cut or stick needles into people, and he could treat people that way. And yes, I'm a surgeon, but I always try less and less invasive procedures in surgery. And Dr. Andrews taught me that during my fellowship that to do minimally invasive surgery. And I also learned from Dr. Bradley, who was the Pittsburgh Steelers team doctor, about PRP, platelet-rich plasma. And that's how I got interested in regenerative medicine and trying to get people better. But it came from that day where I was told there's no way to repair a knee and you can only replace it. And that's why that's been my mission over the years. It's been a long time. But with the use of regenerative medicine and other things, yes, we have a trademark knee repair, not knee replacement process and programs. But regenerative medicine, the principles are work for any joint, and that's the beauty of it. Now, we don't necessarily do necks or backs, but lots of shoulders, hips, hands, elbows, ankles, etc. We've helped a lot of people avoid Tommy John surgery by using these same principles. So the principles of regenerative medicine can be used on any joint. Knee repair, not knee replacement, is really more of a total program thing. And it's not just regenerative medicine. It's not just a shot and see you later. I started doing that, frankly, in the 1990s, 2008, 2017 were kind of like the landmarks of getting a centrifuge and PRP and doing stem cells and all those things. But those principles work for any area of the body, not just the knee. It's just that we do have a proprietary program for knee repair, and that's why we are the home of knee repair, not knee replacement, if that makes sense. But it stems back to all the way back when I was a medical student and I was told you can't repair a knee or you can't remodel it or you can't. And frankly, we absolutely can repair the bone and heal the bone and cure the bone problem. The cartilage is coming along. There are some studies that show you can grow some cartilage back. We can definitely remodel the inside of the joint, but in the long run, yeah, we want to grow back cartilage and make that knee look completely normal. But even if that's not possible, the most important thing is preventing a knee injury or knee arthritis in the first place. And I think that's where that's how we're going to prevent the need for knee replacement by the year 2043. It's going to not be treating people when they're bone on bone, even though we can do that. It's going to be getting the word out and being proactive, preventing arthritis in the first place. So that's a long answer to can the principles of knee repair, not knee replacement, and regenerative medicine be used on other body parts? And the short answer is yes, they can.
Yeah, for sure. Got one last question for you before we hang it up for today. Why is it more difficult for me to go downstairs than upstairs? It's different for
Okay.
everybody, but this particular question was, why is it more difficult for me to go downstairs instead of upstairs?
All right. So the question is, why is it more difficult to go downstairs than upstairs? And you being an amazing total body VFit specialist who is a PTA, physical therapy assistant, and a certified strength and conditioning specialist, I am going to throw that question back to you to explain why that is. I mean, I think we all know why, but I want you to explain it because you're the one who has to deal with it and help these people to not only go up the stairs, but go down the stairs. And you have to train them for both, and it's different training for both areas and different muscles, etc.
Right. So first, I just want to talk about the mechanics of going up and down the stairs, especially of the way that the muscle fires when you're going up the stairs. It's called a concentric contraction. The muscles are shortening when they're being activated, um, which puts less pressure on than going down when you're doing an eccentric contraction, which is when the muscle is contracting while it's lengthening. So that takes more control. It takes more fight against gravity when you're going down eccentrically. And I think that's a big thing with the quads, especially with knees. When you get swelling in the knees or you're off your feet a lot, that quad can atrophy pretty quickly. So making sure that you're getting the strength and the eccentric control will help when you're going down the stairs. But if you're not using your knee a lot and you're not using those muscles, it does make sense that when you're going down, that muscle is not able to support the knee as well. Another reason is when you're going down the stairs, you need a lot of ankle mobility. And a common ankle limitation is dorsiflexion, when you're going down the stairs, you need that knee to travel over your toe. Um, in order for to get the knee bend and get the quad to fire as well. But once that knee is going over the toe and that ankle is limited, it's going to put more pressure on the knee. It's going to put more pressure on the knee, on the ligaments, and the last thing I would say is like hip strength, the single leg when you have to have that one leg planted down. It can cause your knee to go into valgus once you start to bend it and you go down. But little things like that, I think the biggest thing is the eccentric strength and the ankle mobility.
Gravity on the way down, a lot over on the way up. But yeah, so that's why I had you explain that. Great job.
Yeah. Well, Doc, thank you so much for answering these questions today, and thank you to all of our fans for submitting them and on social media and on here. We appreciate it, and we love answering the questions. If you have any more and you would like Dr. P to answer, please be sure to join our school group linked in the description below. As of the date of this recording, it is still free to join, so definitely take advantage of that. Be sure to follow us on social media at Victory in Motion 1, and be sure to follow Dr. P on social media at Dr. Marc Pietropaoli, and that's Mark with a C. We will see you on Ask Dr. P next Wednesday at 9 a.m.
Thanks, Lucci.
Thank you,
Thank you
Doc.
for answering the question, and thank you all for submitting the questions. And have a great week.
Yeah. See you next
Take
week.
care. See you next week.